Certainly. So what I'm talking about today is integrating risk factors to more precisely predict outcome in paediatric acute lymphoblastic leukemia. So as many people will know, minimal residual disease, or MRD, is one of the most predictive biomarkers that we have within paediatric ALL. And the question I'm addressing is, can you use that alone to predict outcome, or should you integrate that with other risk factors such as the tumour genetics, the age of the patient, the white cell count, etc. So we've done a couple of very large studies based in the UK, which have now been validated in independent cohorts across Europe, that show really, in order to get the maximum value out of your MRD measurement at the end of induction, what you need to do is you need to put that into the context. What's the genetic subtype of the leukemia, how old the patient is, and what their presenting white cell count is. And you can do this at two levels. You can just merely integrate the MRD level and also genetics to more precisely refine what the MRD is telling you about the risk of that individual patient. Or you can actually integrate multiple risk factors into a single prognostic index. The first example, where you're integrating just MRD and genetics, what you really need to do is define genetic-specific MRD thresholds in order to better refine whether a patient's likely to relapse or not. If you take the second example, where we're looking at the prognostic index, what that enables you to do is assign an individual risk score to each individual patient, and then you can use that in a kind of study or a clinical trial, where you can divide up your entire cohort into patients with different risks, and therefore derive different treatment risk groups, where you might want to consider the patients at the very low risk of relapse for some kind of treatment de-escalation. Those at the very highest end, you might want to consider more experimental chemotherapy, and the ones in the middle would be the kind of randomization to the next, to an important drug. So currently patients are initial diagnosis, bone marrow sample is taken, and you look for an MRD marker. That's a kind of leukemia-specific marker that you will track during therapy. And the most common time to do this MRD assessment is at the end of induction, which usually lasts for 4 or 5 weeks in most of the major protocols. And that's the kind of major investigation that's done in acute lymphoblastic leukemia. In addition to that, you will always do a kind of standard genetic workup to find out what genetic abnormalities are present in that particular leukemia. And we've been doing both of these techniques independently for many, many years now. The advantage of the work that I've been doing over the past few years is actually to integrate those two pieces of information into a kind of single risk factor. Right, so rather than think about the MRD and the genetics completely separately, you think about them together, and you start adjusting one level, the level of MRD for the genetics, and that gives you a more precise measure in order to predict outcome. Right, so personalising therapy for patients is kind of quite difficult concept, really, because of course there are lots of patients and there are only a limited number of therapies we actually have. But what the genetics can do is, if you have a specific genetic abnormality that we know is sensitive to a particular drug, you can introduce that drug into the protocol for that specific patient. And there is an example that we've been doing on a completely separate study that I'm not actually talking about tomorrow, where a group of abnormalities called ABL class fusions, which are sensitive to a drug called imatinib or dasatinib, a class of drugs known as tyrosine kinase inhibitors. What you can do is you can measure a patient's MRD response at the end of induction. If that response is not very good, what we've been doing in the UK is testing those patients for these rare ABL class fusions, and where they're present, we then add imatinib into their therapy at that point in time, and we've got preliminary evidence to suggest that that has dramatically improved outcome in this rare high-risk subset of patients. So that's kind of getting towards personalised medicine. Obviously, it's tuned to the specific tumour type rather than the person, but it's heading in that direction. I just think everything that I've talked about really has been paediatric ALL. So this really accounts for everyone up to about the age of 25. But we've been doing all the same kind of research in adult ALL. So this is going up to patients who are 60, 70, 80 years old. And essentially, all the same concepts come out. I mean, the number of patients that we have to analyse are much smaller because acute lymphoblastic leukemia is rarer in adults, and it's slightly more challenging. But I do think that over the next few years, all these advances that we're making in paediatric ALL will translate in some form to treat adult ALL far more effectively, because at the moment the outcome of patients with adult ALL is significantly less than paediatric ALL. So we really do need to translate these ideas. They're not all immediately translatable because obviously you have to adapt it for the particular setting, but I think the concepts and the ideas will be translatable into adult ALL to improve the outcome of those patients as well.